come out every day that are showing it is more genetically linked than anything. We know this because there's a huge familial link. Just last week, not to me, there was a kiddo that I wanted her to get some practice doing an exam on an autistic kid. It's good practice. And I said, observe mom too, because I really think she's on the autism spectrum. And Nandini came out and she was like, yeah, I get it. You're totally right. Her communication was very different. Her eye contact was really poor. So a lot of generation of our age and slightly older that didn't have as good of screening, they may have just learned, they had mild symptoms and they may have just learned how to cope. They may have developed their own coping strategies. So yeah, definitely familial link. Our twin studies, there's definitely a link in twins. There's an increased risk if one twin has it. Pretty common that the other one has it. Not always to the same degree. We're not sure what causes that. And we have found several genes that are very clearly markers of autism spectrum disorders. Way more prevalent in the male gender. We think that there's got to be some kind of a link on that Y chromosome of why males are more commonly affected than females. We think there may be an environmental link. I don't know, maybe something in the pesticides or the plastics we use. There's a huge component of people out there that swear vaccines cause autism. It is absolutely not true. We've got over 20 studies showing it's not. Some people blame it on mercury and water. Some people think that it has something to do with the growth hormones we're putting in cow's milk. There's a lot of theories out there. It's important as a clinician to know what those theories are. Like, I regularly read all of those mom blogs that I don't agree with and I don't believe, but I want to be prepared. If I have a patient come in and that mom says, oh, well, I read, blah, 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 you can immediately say, oh, I read that too. And you know what? I understand where you're coming from, but here I've got 5 other studies showing that that's not the case. Okay, so sometimes you have to go behind enemy lines and kind of figure out what you're going to say to those patients to bring them over back to the light side. All right, so early infant symptoms. One of the most common things that we see with little bitty babies, I'm talking like 2 and 3 months old, is lack of eye contact. A study came out a year or 2 ago that, it was a European journal that published it. They used computer algorithms to monitor eye tracking movements of like 2-month-olds, and they could predict autism 60% of the time just based on their eye movements at 2 months of age. I think that's incredible. So that goes to show, while the symptoms of autism may not become very prominent until the kiddo is like 12 to 18 months old or sometimes even older, we can identify signs that early. Lack of eye contact while nursing or eating. We've been talking back about breastfeeding and how bonding that is. It's interesting to think a newborn and an infant, their range of sight is about the same range of distance as it is when mom is nursing that baby to mom's face. I think that's pretty cool. These babies, sometimes it's a bad thing to have a baby that is never fussy and never cries. You want to see, you know, if they get irritable, if they get really cranky when they're hungry, if they're super cold or hot, you want to see them cry. Sometimes these babies are a little too placid. They seem remote, you know, there's between 2 and 4 months that baby's going to start getting really social. They want to see what's going on, they want to sit up and check it out. If they've got brothers and sisters, they want to watch them play. Sometimes these little guys, they just don't seem that interested in what's going on. They may be more interested at, you know, the ceiling fan or staring at a spot on the wall. The big one to remember is delay in joint attention. Joint attention we start to see anywhere around 9 to 12 months, sometimes a little earlier. And that's, you know, you've probably seen little babies with their moms. They get interested and they want mom to look too. You know, as they get older, they'll be very demanding about it, like my little stinker. Mama, look. But you can see that even in nonverbal kids by them, you know, grabbing or they touch mom's face and they want that joint attention. It's a part of social development in these kids. They want their caregiver to be interested in the things they're interested in too. All right, here's some red flags that well checks when they get older. We do routine screenings at 18 and 24-month well checks. There is a great tool called an MChat. MChat is indicated for kids between like 16 and 30 months of age. Super fast, 1-page questionnaire. It's like 28 or 30 questions, and it's easy yes or no type questions. It takes parents like 5 minutes to do. It's a great screening tool. Not diagnostic, it's a screening tool. You especially want to start administering screening tools and being on the lookout for kiddos who have a family history. You know, if you are meeting a new patient and they say, oh yeah, my brother has mild autism, you definitely want to be screening these kids a little more aggressively than somebody without any family history. But especially if you ask about at that 12-month checkup and you say, are they showing you things? Are they excited to learn and they want you to look too? And the mom's like, well, no, not really. He kind of just does his own thing and doesn't really care if I'm looking or not. That's a big red flag. That's definitely not normal. Also, by 12 months, they should be at least saying mama, dada, maybe baba, or just depending what they see in their everyday environment, at least one, maybe two other words. If they aren't saying any of those, upon seeing mom or dad by a year of age, they aren't saying mama, dada, that lack of communication is really concerning as well. I've got a link, I probably don't have time for it today, but if you guys want to watch, I've got some great videos embedded in here that you can look up, instances of kiddos who've been diagnosed with autism and the behaviors that actually looks like. That helps me. I still like watching them. I learn every single day. There's always something else to learn about autism. New behaviors are identified. It's kind of one of the things that our generation of clinicians, I think, we're going to make a lot of progress in. At least I sure hope so. Not responding to their name, that's a huge red flag. I think in that video there's an image of a little boy sitting on the floor playing. You can hear his mom calling his name. I think she's like, Gabriel, Gabriel, and he is not turning around. Versus, after a few times, even if the kid is engrossed in what they're playing with, after a few times of their mom screaming their name at them, they generally will turn around to see what's going on. That's one of the signs that we see most early on with kiddos with autism. And then listening to the parent. Being in pediatrics is a very interesting dynamic because you're treating your patient, but really you're treating the family too, and learning to trust the mom or the dad or grandma as the historian, because they know that kid best. And if I have a grandma bring in, a little guy in that she's saying he's just not eating, he is not acting right, I'm going to listen to that. If her gut says something's really off, I'm going to trust her and I'm going to do a full exam, and if I find anything, I'm going to do a full workup and see what's going on. There's a lot to be said for kids' behavior. And then, I threw that in there twice, the family history of ASDs. Okay, so here's an in chat. I just want to give you a quick example. You can kind of read those questions real quick of the type of things it asks. Okay, so a lot of these things you can observe during the exam yourself, but it's good to have mom, especially from her eyes, you may see the child do it once on exam, but it could be a fluke deal, and mom says, no, they actually never do that at home. So it's good to have the primary caregiver fill this out and get a clue in as to what the kiddo is doing at home on a general basis, because what we see as clinicians is a very brief snapshot of what a kid's behavior truly is. And they act totally different when they come into your exam office. I have some patients that bounce off the walls when they come see me, and the parents are like, they never do this at home, what do you guys put in the water here, I don't know. And then I have some kids that clam up and will not say a word, and the parents are just baffled, because at home the kid is a total diva, they sing and dance, and then on the exam table they just sit there and won't say a word. So trust the parents' judgment, and these questionnaires are a great way to get a big picture on things. All right, toddler age symptoms. We're moving kind of beyond those initial delays of not responding to name, joint attention. Toddler aged and older, we can break this down into 4 big areas. Communication, behaviors, tantrums, social skills. The little icon you can kind of read and glance at later. Those are just some of the warning signs that we're talking about. All right, so communication. It could present several different ways. They may just not be talking, that's one. But I have some kids that jabber constantly, but they never jabber with any sense to it. I even have some kids that are elementary age that I take care of that their vocabulary is excellent, and they say all kinds of words, they talk, but it may be more like echolalia, like they just repeat what you say. They never really say anything with meaning. They can't answer questions correctly. That type of speech should be present by 3. I always start off my exam, I give my kiddos a high five, or if I know them really well, I'll give them a big hug, and okay, we just had Halloween. So by 3, I always give them a hug and I say, did you have fun at Halloween? And they should at least be able to say, yeah! And then my next question is, well, what did you dress up as? Most 3-year-olds remember what their awesome Halloween costume was, and they cannot wait to tell you all about it. But if a 3-year-old kind of looks at me like they don't really know what I'm talking about, or if a 3-year-old looks at me and says, costume, and it doesn't really mean anything, that's kind of a red flag for me. So really, your exam starts the minute you walk in the door, and that, it may not be something you're specifically saying to the kid or testing, you guys know your neuro exam, you may not be having them spell words or do anything specific, but in kids, your observations are just as key to identifying any type of behavior or developmental abnormality. So the other thing to note is a lot of kids, they may have a verbal delay, but they will sign or mime. We taught Mira some sign language, and it was great. Her first sign, she started signing at like 6 or 7 months, she started signing milk. So if she had kept going and not started developing any language, but she was still miming, I wouldn't be super worried. If most kids are picking up new signs, that's a good sign that that part of their brain is working the way it should be. They just haven't made that connection yet into the motor part of their brain to actually form the words. So a little bit of speech therapy usually goes a long way with those kids. The other really concerning thing is any type of regression. There's a type of autism spectrum disorder called Rett syndrome. It's a genetic female condition, only little girls get it. I have a little girl, she developed totally normally until she was 2. She was talking, she was singing, she was dancing, and then she lost it all. And now she's severely autistic and nonverbal, so that scares the crap out of me as a mom. But so any type of regression, if a mom comes in and is like, well, they had been saying all these words and now they're just not, work that up immediately. Very impaired in conversational skills, so we were talking about, 3, 4-year-olds, if you ask them, what was your Halloween costume? And they may go start talking, okay, I have this one little girl that she's 4 now. She has excellent verbal enunciation and vocabulary, no syntax or context to her speech whatsoever. Like I would start asking her about her kitty cat at home, and she would go start talking about Cheetos. I mean, just no logic sense to what they're telling you. Stereotyping language, so I was just talking with somebody earlier that they know someone who's affected by some type of a neurodevelopmental disorder, and when they get excited, they may hear them say, yeah, 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 yeah. So that's called stereotype language. Or if they just repeat the same thing over and over. I have a cousin that what is his word that he says? Cup. He says cup over and over. It doesn't mean cup, it's just a sound that he uses to express his frustration. And you can tell based on the context, but that's, if they say the same thing over and over and over, then it might be an autism type behavior. Then as they get a little older, lack of very spontaneous make-believe play. Generally, around 18 months, you see kids start pretending with objects. I mean, baby dolls, or even like a block that they hold up to their phone and pretend like hold up to their ear to pretend like it's a phone. You start to see that kind of make-believe happen around 18 months to 2 years. And if you're not seeing that and they're not talking about, all the things they're pretending, that's a big red flag as well. Okay, abnormal behaviors, and movies are very good about portraying abnormal behaviors. Just because you see a kid do an abnormal behavior once, in the movies, you see people that constantly hand flap, but that's not really how kids with autism behave. They may do a behavior only when they're excited or only when they're frustrated, and some days they may not do it at all. But hand flapping is a really common one. When they get really excited, they flap their little hands. Or oral fixation. A lot of my little girl with Rett syndrome, she, bless her heart, puts everything in her mouth. Actually, one of my little boys I take care of does too. So I get stomach bugs a lot. I get sick a lot. And they don't just touch it to their lips. It's very common for most toddlers stick everything in their mouth. But even as an older kiddo, they lick it or put their tongue on it. Just kind of weird behaviors. Not trying to eat it. Like most toddlers are just kind of tasting it to see, what does this taste like? Head banging, either when excited or overstimulated or frustrated, that's a really common one. I have one little boy, he's 8 now, he bites his arm when he's really upset. That's so hard to see. Spinning and rocking, that type of vestibular movement has a calming influence, so if kids are really overstimulated, Occupational therapists will have parents set up like a swing in their house so that they can go kind of get away. And that swinging movement, like kids will try to imitate by themselves by rocking, they can get that calm feeling from swinging. When they play with toys, they don't play with them like you would expect. They might be like, say, a toy car. You might see them sit there for a full 15 minutes spinning the wheels on the car. Kids like to do that. They don't like to do it for a full 15 minutes. So they just don't play normally with the toys. And they, all toddlers like to push buttons on electronic toys. This would be like half an hour they sit there and push buttons as they sit there and like rock. It's just one of the behaviors we see. On the whole autism spectrum, the most common thing that I see is a sensory integration disorder, where that stimuli that kids are feeling, and when you think about all the information our brain receives, it's a lot. And kids with autism, they can't process all that information at once. I mean, just right now, standing here, I'm seeing you guys, I'm feeling the clothes on my body, I'm feeling my scratchy throat starting to give out on me, I can tell the temperature in the room, I can hear a humming from the light. That's a lot of sensory, and for a kid with autism, just that may be too much. So imagine like going to the mall or to a park, that may be way some stimulus overload for some kids. But even kids without the more severe end of autism, that they may have more just like sensory integration stuff, I'll see parents come in and say, my kid, like a 6-year-old, they're really picky about what clothes they wear. They complain that they itch or they hurt. They never want to wear tights or socks. That's a big one. They're just super sensitive. They will only use like a certain temperature of water. And a lot of those, and as you practice, you'll start to hear more and more. A lot of those can be a sign of a sensory integration disorder, which occupational therapy can help a ton. It kind of helps rewire the brain to be able to process that stimuli a little different. But kiddos with autism can be super picky about what clothing they wear, what texture foods they eat, and even just kiddos not even on the spectrum. But sensory integration problems are very common, especially when it comes to eating in kiddos. The social skills things that you're going to be looking for, typically by 18 months, those kids are at least interested in what other kids are doing and playing. They probably won't play cooperatively until, much later into their 2s. But they should at least want to play side by side and kind of participate in an activity that other kids are doing of a similar age. Poor eye contact with adults and other kids, they avert eye contact. Now this doesn't mean they'll never look at you, that's not the case. And I even have some kiddos that they are on the severe end of the autism scale, and the older they've gotten, they've lost that and they will stare at you. So that's not always the perfect diagnostic sign to that. Same thing, failure to responding to their name. We see that in little infants, but even as older kids, they still continue with that not responding to their name. Not interested in other children, not interested in play with parent, they prefer to play by themselves. As parents, we try and get down on the floor and engage them and play with them, but these kids, they don't look at you, they turn away, they run off and just kind of are in their own world. They're not interested in engaging with their parent. That video link is great. And I think that might be the link that it's actually twin boys, one with autism and one without, of how differently they interact with their mom when they're playing with cars or blocks. Again, back to that shared attention, that will turn into later on as a toddler, Mommy, look what I did! Mommy, look, watch me, watch me! And kiddos with autism, they're just not interested in that type of social interaction with their caregivers or with their teachers or any other kids. Tantrums. So any deviation from a normal is a hard stimulus for kiddos on the spectrum to deal with. A new shirt, some kids are super picky about their shirt and will only wear a certain one. They'll only eat a certain food for breakfast. They have to watch a certain show until it's done, and if you have, for whatever reason, if you have to leave early, they lose it and have a tantrum if you have to go early. Now, you're probably saying, don't all toddlers have tantrums? And yes, they do. Toddler tantrums are usually goal-oriented. That's the big difference. If so my kid throws a tantrum when I take away her pacifier, or if I take her away from playing and it's time to go get pajamas on. Yeah, she may throw a tantrum, and I just leave the room and ignore her. And she'll calm down. Give her 30 seconds to 2 minutes. She's fine. She had to get it out of her system. Yeah, she was ticked, but now she's all right. Kiddos with autism, they can't self-calm, they can't self-soothe, they may start headbanging, they may start flapping, they may rock to try and help self-soothe. And it's not always goal-directed. They may just start having a tantrum for no reason. And a lot of times, I always wonder when I go to the mall and you see a kid melting down in the mall. Yeah, kids who are overtired may do that, but I always wonder, I wonder if that kid's on the spectrum. So want-driven, goal or control-driven, an audience to perform for. Like I said, if my kid starts throwing a tantrum, I just leave the room. She can get it out of her system and then come find me when she's done. So it's funny to watch some toddlers, 3-year-olds are notorious for it. They will follow you around, and as soon as they find you, throw themselves on the floor again, start screaming, leave the room, they'll come, and start throwing. That is not an autism meltdown. That is a typical toddler tantrum. But autism meltdowns, safety is compromised. We talked about the head hitting, the biting, that kind of thing. And it's not goal dependent. There's nothing you can do or give the kid or fix. It's not going to fix it. You just have to help soothe them. Any Grey's Anatomy fans in here? Okay, you remember the super old episodes that there was the cardiologist? I think it was Dr. Hahn. No, it wasn't Hahn. It was one. Okay, and so she started having, it looked like a panic attack, but that was the equivalent of an autism meltdown. And she said, hug me. Hug me. And Christina Yang was like, what are you talking about? Hug me. And she said, no. Hug me and put that tightness, and my central nervous system will calm down. That's really true. We do that for kids with autism. If you sit down and pull them into your lap and bear hug them, it helps a lot. So we have, a lot of times you'll see like on Facebook, people sell weighted blankets, even people without autism. I like a heavy quilt, you feel nice and snug under a heavy quilt. Kids with autism love weighted blankets. They love small spaces where they can go in a dark, quiet, stimulus-free environment, curl up, they feel nice and safe. All right, so I just want you to look at these terms. This whole umbrella of autism spectrum disorders, I think over the next 5 to 10 years, the way we, like ICD-10 codes, the way we classify things under an ASD is going to change drastically. We don't really recognize Asperger's anymore. We just call it a high-functioning ASD. But that term is still used a lot. So older clinicians, you'll hear the Rett disorder, that's the chromosomal I was telling you about. I have a little girl that has that. And then sometimes a developmental pediatrician will diagnose them as pervasive developmental disorder, PDD. So if you hear or see that term PDD, know that it falls under autism spectrum umbrella. Okay, a few conditions that can present, and we've already talked about Fragile X. Another one is called tuberous sclerosis. If you are noticing any abnormal facial features with a kid who has autism-like behaviors, get the chromosome array. See, maybe they've got Fragile X or maybe they've got tuberous sclerosis. Especially if they have some weird skin lesions, this might be tuberous sclerosis. ADHD, I have some kids in my practice who are so strong ADHD, it does impair their communication, their social skills, and their cognitive ability. And once they get on meds, it's like it all goes away. It's incredible. But a lot of it can present like an autism type behavior. Kiddos with OCD, they may have like stereotyping movements, but it's not because of an autism spectrum disorder. It's because in their mind they feel like they have to do that as a control type thing. It helps soothe them to repetitively, bite their arm or pinch their fingers. And it can look like an ASD type behavior, but it's actually OCD. So any of those, a developmental pediatrician is going to help you diagnose autism versus a different type of disorder, but those are just kind of the basics to keep in mind. All right. Woo! It is 3:30! Yay! Any questions on